Hi, let's talk about the rectum and the anal canal. In this video, we'll discuss the locations, muscular layers, and structures of the rectum and anal canal. The rectum is a continuation of the sigmoid colon and thus a part of the large intestine. That rectosigmoid junction is approximately at the vertebral level of S3. When we think of the layers of the rectum, they're all the same, but they're slightly phenotypically different than the layers of the remainder of the large intestine. So, for instance, the outer longitudinal muscle of most of the colon is condensed into ribbons of the tinea coli, which leads also to a sacculated appearance of the colon. So we see hostry. Whereas in the rectum, that outer longitudinal layer of muscle is contiguous all the way around. So there's no tinea coli, there are no hostry, so it's not sacculated whatsoever. It's going to have more of a smooth appearance from a serosal view. From within the liver, we can see invaginations of mucosa that are known as rectal folds. These rectal folds or transverse rectal folds are somewhat constant and reliably located, especially even when the rectum is distended with feces. As we look also, the distal portions of the rectum, which we can see here, are quite dilated, and that region is known as the rectal ampulla. The rectum itself, as a continuation or as a part of the gut tube, is going to pass through the muscles of the pelvic floor. So it's going through levator ani. In fact, the closest portion of levator ani is going to wrap around the distal portion of the rectum, and that portion is the puborectalis muscle. And so the rectum will be oriented sort of infero-anteriorly, and then the anal canal is going to take a sharp bend posteriorly because of that puborectalis sling that wraps about it, and we'll see how that works. The rectum is supplied by a couple of sources of arteries. So here we can see the abdominal aorta, and there is the inferior mesenteric artery, and one of its major branches is the superior rectal artery, which we can see here. That superior rectal artery is going to really supply the entire length of the rectum with blood. Coming off of the internal iliac artery here, we can see an anterior branch called the middle rectal artery. That middle rectal artery is going to supply more of the proximal portions of the rectum with blood. Sometimes it has branches towards the distal rectum and the anal canal, but not as significant a source of blood to the distal rectum and anal canal as is the superior rectal artery. In terms of innervation of the rectum, it still has the enteric nervous system, which is extrinsically controlled by the autonomic nervous system. Specifically, in this case, the inferior mesenteric plexus, which has a middle rectal plexus, which supplies the rectum with innervation. In terms of the sympathetics, those fibers are coming down from the superior hypogastric plexus in the intermesenteric plexus. as well as the inferior mesenteric plexus here. We also have some sympathetics that can arise through the sacral splanchnic nerves, but those are going to be a minor contribution to the rectum. In terms of the parasympathetics, those are coming predominantly through the pelvic splanchnic nerves. Pelvic splanchnics are branches from the ventral primary rami of sacral nerves 2, 3, and 4. And those branches are going to feed into not just the inferior hypogastric plexus, but also will have an independent pathway out of the pelvis to serve the hindgut in totality. Now, beyond the rectum is the anal canal. And so we have this anorectal junction, and we can see that they are faced differently, with the rectum more inferiorly and sometimes even a little anteriorly. But that anal canal has a distinct posterior orientation to it, and that's complements of that puborectalis muscle, forming a sling around that. The anal canal is continuous with the anus. It is divided up into a proximal portion, which we call the proximal 2/3 of the anal canal, and then there is a distal 1/3 of the anal canal. These two regions have distinct embryological origins, and so their pattern of blood flow and innervation is going to be distinctly different, and we'll address that on a future slide. But suffice it to say, when we look at the mucosa of the proximate anal canal, so the proximate 2/3 here, we can see that there are mucosal invaginations here, and they form these columns here. They're called anal columns. They tend to be more constant in younger individuals and more inconstant in older individuals. And the spaces between these anal columns are known as the anal sinuses. See that there. When we go down to where the columns and the sinuses meet, we have something known as the pectinate or dentate line. That pectinate dentate line is going to distinguish the proximal anal canal from the distal anal canal, and various patterns of neurovascular service. Now, when we look at the proximal and distal anal canal, we can see that they're both surrounded by musculature. And so here we can see this would be the musculature represented by the colon, and outside of that is the musculature represented by the external anal sphincter. And so we're going to see that there are actually two distinct types of muscles derived from the colon. One part of that is going to be the internal anal sphincter, and the other part will be longitudinal muscle, and that longitudinal muscle is going to separate the internal anal sphincter, or the IAS, from the external anal sphincter, or the EAS. And let's take a look at that now. So we can see in this cadaveric view here, we have the internal anal sphincter. This internal anal sphincter is a continuation of the innermost layer of the muscularis of the colon, specifically that circular layer. It's not truly circular like most sphincters are. It's more of a spiral orientation, which is reflective of its origin from that layer of the muscularis. As it is smooth muscle, and as it is of kind of the hind gut, that internal anal sphincter is going to be under autonomic control, specifically from the inferior hypogastric plexus. Likewise, there's longitudinal musculature. Sometimes this is called the conjoined longitudinal musculature. This is also derived from the longitudinal musculature of the hindgut, so it's contiguous with that longitudinal layer of the rectum. So it's smooth muscle, and it is also autonomically controlled by the inferior hypogastric plexus. And then finally, on the outside here, we have the external anal sphincter, or the EAS. And that external anal sphincter, let me write it here so we can see it, is skeletal muscle. It is innervated by inferior rectal nerves, which are branches of the pudendal nerves, so from the sacral plexus. So let's take a look at some of the divisions we have of the anal canal and the consequences of having different embryological origins here. So let's just point out, here is that pectinate or dentate line, and what is above this line, so the proximal anal canal is going to be distinct from what is distal to this line, or the distal anal canal. So let me go through sort of vessel by vessel and contrast these. So proximally, the blood supply to the proximal 2/3 of the anal canal is going to be complements of the superior rectal artery. Some sources will say that there are some contributions from the middle rectal artery, but the predominant blood flow to the proximal anal canal is the superior rectal artery, versus the inferior or distal portion of the anal canal is supplied by the inferior rectal artery, which is a branch of the internal pudendal artery. Superiorly, draining the mucosa, we have tributaries that are going to coalesce into the superior rectal vein. This is part of the portal system, whereas inferiorly, those portions are drained by inferior rectal veins, which drain into the internal pudendal vein, which is caval. So portal above the pectinate line, caval below. Now, there can be dilations of both the veins within the superior mucosa and in the inferior mucosa. Some terminologies will refer to these dilations as hemorrhoids. So internal versus external hemorrhoids, depending on their locations. So for instance, an external hemorrhoid would be a dilation of the mucosa, complements of dilations from the caval portions. These tend to be itchy and even painful. That's because we're experiencing true pain, because this is somatic, because the innervation is complements of the inferior rectal nerves, which are somatic in origin because they're branches of the pudendal nerve, versus quote-unquote internal hemorrhoids, which are dilations of the mucosa from tributaries of the superior rectal vein. Now, there are also issues in delimiting hemorrhoids from anorectal varices. Anorectal varices are going to be dilations of the veins in the mucosa that are from portal hypertension, oftentimes as a result of cirrhosis. And so sometimes these concepts get confounded between the two. And generally, people will very frequently refer to internal hemorrhoids as anorectal varices. And this is a very small incidence in the general population. And it tends to not be as diagnostic as esophageal varices in diagnosing portal hypertension. But nevertheless, this tends to be discussed. In terms of lymphatics, any lymphatic drainage of the proximal anal canal tends to go to the internal iliac nodes, whereas the drainage of lymphatics from the distal anal canal tends to go to the superficial inguinal nodes. And we'll discuss those superficial inguinal nodes in the context of the lower limb. Ultimately, that lymph from the superficial inguinal nodes will go to deep inguinal nodes through common inguinal nodes. So that lymph is going to reach the same pathway as the lymph from the internal iliac nodes, just a different route, and we'll see that as we move forward. So we've discussed the rectum and the anal canal, the neurovasculature, which serves different portions of the hindgut here. This is your summary slide. Thank you for your time.